Hi, Professor and classmates. Jenny Hackenberg. I'm doing my SOAP note for this week. My patient's name, A.L. His age, 56. He's a Caucasian male. Chief complaint, he can't. I just came in to get checked after being in the hospital this week. So HPI, of course I said Al is a 56-year-old male. He's a reliable historian. He does have a history of recurrent community-acquired pneumonia, and he presents to the clinic today alone. On 1/22, which was Friday, AL presented to the clinic with a friend in respiratory distress. He was immediately stabilized and sent to the ED at that time. Once he got there, he was admitted to a regular floor, and he stayed for 3 nights. And it was once again diagnosed with community-acquired pneumonia. So, review of systems. He reports feeling a little bit warm and tired from not getting much sleep due to being into the hospital and due to coughing several times throughout the night. He does report that he has had less of an appetite, but that he was still eating. He has not lost any weight that he's noticed. Cardiovascularly, no issues. Respiratory, he does report pain to his right side with deep inspiration. He does have shortness of breath. He reports a productive cough that's clear and mucus. He denies wheezing or orthopnea or PND, as well as hemoptysis. No GI or abdominal problems. Last BM this morning. No GU problems. For musculoskeletal, he did report pain to his anterior, posterior, and lateral side of his torso, and he believes this is due to coughing. Past medical history. Of course, the community-acquired pneumonia. He came to our office October 1st of last year, and he was diagnosed with it then. And then, like I said, on Friday. He is a smoker as well. I don't think that should be included right there. I'm sorry. Preventative care, nothing to really mention except for he's up to date with colonoscopy, dental, eye exam. He did have his influenza vaccine, and he was obviously here last Friday when he was diagnosed with a pneumonia exacerbation. Surgeries, routine colonoscopy showed some polyps were benign March of 2019. Hospitalization, just the surgery that he had, and this last round of community-acquired pneumonia. Allergies, he is allergic to penicillin, and it does cause anaphylaxis. Medications, 750 levofloxacin. He's been taking that for once a day for 5 days. He started it Friday. His last dose that he took was today at 9 a.m. His family history includes mother and father that have high cholesterol and hypertension. Social history, he's been addicted to nicotine for quite some time. He's a 20-pack-year smoker. He denies using illegal drugs. He quit drinking in 2015. He does report that he lives with 4 roommates in a 2-bedroom apartment that he rents in a neighborhood with a pretty high crime rate. He doesn't have a very healthy diet. He eats meat and potatoes, and he drinks sodas all day long and coffee in the morning. And next, objectives for his vital signs. The only thing out of the ordinary was an SpO2 of 95%, pain score of 4, and his BMI was 24, so he was in a great range there. Diagnostic test. I noticed when I walked in the room, he was well nourished. He was roughly groomed. He was in slight distress while he was in the office because he was guarding his ribs from hitting the arms of the chairs. He's alert and oriented ×4. He's easily comprehensible. His skin turgor was fair. He seemed to be a little dehydrated. His mucous membranes were a little dry as well. Next thing I noticed, cardio was fine. But the next problem, of course, was the lungs. He had increased breath sounds in the right lower lobe, and there was a little dullness to percussion. I did hear slight crackles, and there were no wheezes or rhonchi present. GI and abdomen, no masses were noted, but I will say there was some tenderness in the right lower quadrant when I percussed, and again, it was more of a muscular issue. Differential diagnosis. I decided it was going to be community-acquired pneumonia due to his history of pneumonia, smoking, and living in a small apartment with 4 other people. Another differential diagnosis would be asthma. I related this to his shortness of breath, cough, and his frequent respiratory infections. And then last one is bronchitis. I related that to the productive cough, fatigue, difficulty sleeping, history of shortness of breath, and that is it. So the plan for community acquired pneumonia: use good hand hygiene, get plenty of rest, drink water in place of your diet sodas, eat nutritious meals instead of your meat and potatoes, include 5 servings of colorful vegetables per day, consider living with fewer people, as overcrowding can lead to an increase of germs and an increased risk for community-acquired pneumonia in the future. It was also recommended that he uses a humidifier. Treatment: he should continue using his antibiotics as prescribed, the 750 levofloxacin once a day for 5 days. He may take 1 to 2 500 milligram extra strength Tylenols for fever or pain if needed. Smoking cessation consult was placed. Pneumonia vaccine should be followed up. It's followed up later. But anyway, he should return to the clinic to get his PVC-13 vaccine in 2 months after his pneumonia has cleared up. And then again for the second shot 8 weeks after that. And then he'll revaccinate in 5-year intervals. And of course, now that he's had pneumonia recurrently, he's going to be referred to a pulmonologist. Education, again, just seek treatment out of the ED if experiencing respiratory distress. No using cough drops, cough suppressants, and of course the stopping smoking. Follow up with the pulmonologist as directed, and then he'll see us back here at the clinic in 2 months for the PCV vaccine. And that is the end of my presentation. I'm including my references along with the DL2 submission. So thank you so much.